Good morning and welcome to today's webcast, How to Benefit from the Medicare Shared Savings Program. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And Karl, I'll turn it over to you to get us started.
Great. Thanks, Emily. Good morning, everybody. Thanks for carving out some time to join us this morning. We're going to talk to you guys about Medicare Shared Savings Program, some of the critical nuances and key characteristics, as well as some important operational tips and tricks, and talk a little bit about how it can be used as an important strategy tool for your organization. I'm joined this morning by Deanna Kyrimis. She is a director in our healthcare consulting group, and Deanna's held multiple C-suite positions in single and multi-specialty groups, among other organizations, including as CEO of, in one example, a very large 50, 60-plus practitioner cardiovascular group in the Phoenix area that took capitation early on, which allowed them to, I'll say, survive longer than many others. A lot of cardiovascular organizations, the physicians ended up going to hospitals to become employed because of the market characteristics, but they were able to withstand the market powers and different aspects of the industry in a very different way because of their business model. She also was the chief executive officer of a multi-specialty group down in San Diego that actually stood up an ACO as well as an associated management services organization, and they were very successful in their ACO efforts. So she's going to be the real star of the program here. As far as myself, I've spent my career in healthcare in finance and operations. I worked for one of the big four for a short spell in their consulting practice in the late 90s. I went and spent some time with Tenet Health Systems, a couple other organizations, and most salient to this, I think, was my position as CFO of Monarch Healthcare, which is an IPA down in Southern California. And, ultimately we were the IPAs are ACOs before ACOs even had the name. So a lot of experience with risk, and we're here today to share some of that perspective with you guys. So again, thanks for joining us. As far as Moss Adams goes, most of you probably have some sense of who we are, but we're a firm that's been around for over 105 years now. Our healthcare practice is quite significant, quite large within the firm. You can see some of the core statistics there. But we really provide services for all of the organizational types within the healthcare continuum, and have a lot of firm experience on the audit, tax, and consulting side with risk-bearing organizations that act like ACOs, health plans, and such. So again, we're very pleased to have you join us today.
All right, our first polling question. What is your organization's current level of participation in CMS MSSP? Your options are A, currently participating, B, considering participation, C, not participating, or D, not sure. I'll give everyone a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. If you're having any issues seeing the polling question, you might try refreshing your browser with F5. Give everyone a few more seconds. And let's take a look at the results. Karl, back to you.
Thank you. So great mix here, and not surprising. The types of organizations I think you all represent today are pretty broad and pretty complex, and so not surprising to see some of the not sures there. But fascinating that we've done this in the past, and the top line typically was a lot less than 30-some-odd%. So it's interesting to see this migrate over time, and we'll get into some of that here in a minute. So in terms of the overall industry trajectory, I'll say, which we try to depict a little bit in the slide here. Ultimately, what we're seeing happen is a little bit of a change from reimbursement focus. Again, we share their shift from volume to value. A lot of folks talking about that these days. The move from fee-for-service medicine over to some sort of a value-based model, which is ACO type entities. Cost is always going to be there as a pressure. But again, what we're trying to convey here today is the ability to use this trend and use these models, whether you're talking about clinical integration in an ACO type of a model or some other version of value-based reimbursement, value-based business. The strategy is, the idea is to deploy these as part of your strategic imperatives because they can create a discipline within your organization that may be a little bit different. Critical to this is the ability to encompass the right organizations within your ACO or within your value strategy to make sure that you've got all the appropriate ground covered. As you might imagine, taking risk is, it's a complex notion, and the depth of your network, the depth of your business partners is much more important than the breadth. And by that I mean you have to have the right folks involved, the right types of entities involved to ensure that you're maximizing the efficiency opportunity as you focus on cost, quality, et cetera. Just in terms of some of the core basics for Medicare Shared Savings Programs, the CMS requires a minimum of 5,000 members for Medicare fee-for-service, Medicare fee-for-service beneficiaries, 5,000 of them minimum to create an ACO. The focus is the three-part aim, also known as the triple aim, which apparently was copyrighted, so folks can't really use that. But ultimately, we're talking about quality, cost, and outcomes. And the notion there is to create greater value in the healthcare system. The quality component of this is really where the core focus is these days. You might remember back to the late 90s, for those of you who were around in the managed care circles at that time, where organizations focused on gatekeeping versus providing high-quality coordinated care. And the HMO system overall almost failed because of that. So this is a very different approach, and folks are really grappling onto that. Again, it's all about care coordination and having the right infrastructure. It's going to require some investment, but ultimately the opportunity there is for gain sharing as a part of this. And I think Deanna is going to talk a little bit here pretty quickly, pretty short here about some of the other value that we see in this, but gain sharing is a part of this, and we have seen organizations do very well even in their first year of this, although we tend to recommend to folks not to set expectations too high in the early years of their ACO. In terms of the history, there were a lot of folks that actually thought that the ACO model wouldn't last early on after the Affordable Care Act was passed. There was a model called the Pioneer ACO, where some of the most astute and sophisticated risk-based physician organizations were involved, and a lot of them backed out after a year or two. Well, the reason they backed out is because their markets were already so coordinated, and they were already doing all of those things that you need to do to be successful in an ACO, so they didn't have an opportunity for a lot of gain sharing. Some of them stuck with it, but where we really see the opportunity is in organizations or in markets where there isn't very tight coordination going already, which I think is pretty intuitive. So now companies are figuring out how to deploy these models, and we're actually seeing the results. So it's pretty exciting time. Then in terms of the new information coming out of Medicare late last year, the idea here is to accelerate the transition, to encourage the participation, and really drive towards the physician-led ACO. Again, that's the power of the pen. It's aligning the incentives, and then the tightening up of the requirements. There were certain strategies that were deployed that were some unintended consequences of the early models. Those are being fixed, and then also driving, and we're going to focus a lot on this, new flexibilities in terms of how you can use the tools that are part of the ACO model.
All right, on to our second polling question. Do you believe your organization is ready for value-based contracting? And your options are yes, no, or I'm not sure. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. Give everyone a few more seconds to make a selection. And we'll close it down and take a look at the results. So we have 35% yes, 19% no, and 44% are not sure. And with that, I'll turn it over to Deanna.
Thank you, Emily. So good morning, everyone. I'm going to just briefly go through some of the changes to CMS Medicare Shared Savings Program, which you'll hear me talk about through the duration of this program as MSSP or ACO, but I'm referring to CMS MSSP, so a certified, deemed clinically integrated network by CMS. So I'll go through the changes pretty quickly, going to dive in a bit to some of the models, but then I really want to get to the power of the CMS waiver and how that can really help drive that value-based shift for your organizations and help with some of those pressures that Karl was talking about earlier. So in 2019, CMS took a look at the models and determined that they needed to make a few changes. They've called it, I think it's the pathway to success, the glide path, but really they were looking at incorporating regional expenditures, and the goal here was to encourage participation among some already efficient organizations, which you heard Karl mention earlier, to improve program sustainability for the continuing participants. They also took a look at blending national and regional trends. Again, this was sort of reflecting of what the market had come forward with as some of the challenges. And the goal here was to ensure that the more market-dominant ACOs, and I'm sure that many of you on the phone or on the webinar know exactly who we're talking about, so large or those rural ACOs, that they're not competing against their own trend while still recognizing those regional geographic differences with that spending growth. So really trying to help, I guess, normalize that, if you will. And then increasing the impact of the risk adjustment. So they were looking here to eliminate the distinction between continuously and newly assigned beneficiaries And the goal is to enable a more accurate reflection of changes in the population risk profile while still limiting incentives to upcode. And I'm not going to go into all of this here, but rest assured that they did take a look at the information coming in and wanted to make sure that they were reacting to it. And then the MSSP model, so many of you who have been participating or thinking about participating, you remember that they were called Track 1, et cetera. With the Pathways to Success that came out December of 2018, they've been changed to basic tracks or enhanced tracks. And then they run through levels between level A and level E. And you'll see that levels A through D do not qualify for the advanced payment model. So when you're thinking about MACRA, those do not apply for APM. They would be moving down the MIPS road. And you can see that level A and B have the sharing rate of up to 40%. Your maximum gain is 10% of your benchmark. And if you move from left to right, you can see how that sharing rate, shared loss rate, maximum gain, and maximum loss change as you shift from left to right, which is upside only, meaning not taking any downside risk. And then as you move further to the right, you're getting into that risk corridor. So the bottom line, when CMS went to make the changes, whether it was around some of the goals with the MSSP or moving those tracks to what we saw in the earlier slide, they really wanted to start moving the MSSPs quicker into downside risk, while the providers were going to have fewer upfront choices, but making sure that they still had choices with that basic plan so that they can sort of dip their toe in the value-based models with upside risk only, while then shifting over into a double side or up and downside risk when we talk about that 2-year window. So I just want to take a step back. And if you're thinking about participating in a CMS MSSP, or you already have been participating, what the difference for this first year is, there's now a 2-year window that you can participate in upside only, or 2.5 if you were able to get your filing in February and start in the stub period, which was July of 2019. So CMS did respond to stakeholder feedback in modifying the benchmarking methodology, which we went through earlier, and they've also really helped to sort of remove some of the application barriers, which we had heard as an industry were really preventing many groups from joining because it was such an arduous process. So now we're going to get into, I think, one of the most exciting things that I've seen in healthcare, and I have been in it for a really long time, more than 20 years, and have always been, faced, I'm sure as many of you are, with that, you've got all the pressures of you've got to control your costs, you're trying to improve your revenue, you need to get physicians engaged, but yet we've got barriers to that. And while they're necessary, some of those barriers have come by way of the fraud and abuse laws that sort of have prevented that real integration that we seek. So what we're going to talk now about is the power of the CMS ACO waiver to help us with that cost reduction, being deemed clinically integrated when we file for our CMS MSSP, and being able to use that waiver in a clinically integrated network to change behaviors and help us grow alliances and our networks that really are developing to collaborate, integrate, and transform the healthcare that we are delivering. So when we look at the MSSP waiver, we're really talking about, as a certified CMS MSSP, whichever track or level that your organization is going down or maybe choosing to go down, you can take advantage of these waivers here, which are pre-participation waiver, which this waiver waives Stark federal anti-kickback statute, gain sharing with respect to startup arrangements that actually predate an ACO's participation agreement with CMS. So I'm going to stop there and just sort of take that one step back again. So what this means, I'll give you an example. And by the way, Moss Adams, we're not attorneys, so please check in with your legal counsel if you're looking to move forward with any of these initiatives. We always recommend, great idea to check in with those folks. But if we take a step back and give you an example, if we were to file for our application in February of 2019, and we were looking to be approved in July of 2019, and this is the stub year I was talking about, we could then start taking advantage of this pre-participation waiver, which deems our network to be clinically integrated. And a lot of us have looked at clinical integration by standing up CINs, which have been terrific. The beauty, or I guess the real advantage of the CMS MSSP is that we're deemed clinically integrated when we move forward with that application. When we get into the participation waiver, now we are just right in with participation. We've got the waiver. We're certified by CMS with our MSSP, and it waives STARK, the anti-kickback statute. We can gain share with respect to any arrangement of the ACO, and we just have to make sure that we're able to identify that it's reasonably related. It's a bona fide initiative that ties back to that three-part aim, and we're going to get into a little bit more of that to just give some more information on the waivers and how we can use those and stay in that legal safe zone. The shared savings distribution waiver waives against STARK and the anti-kickback statute, the physician self-referral law. You can see here the theme, anti-kickback statute, we can gain share, waiver for patient incentives, waives beneficiary inducement, CMP and anti-kickback statute with respect to items or services provided by an ACO. So if you just think through the waiver and programs that you can put together, you can start to see that when we're looking at clinical integration, we're looking at, how do I reduce cost in whether it's my service line or my physician group. I need to get a handle on cost, and we want to improve quality. You can hear that those are, the components of the triple aim, the three-part aim. And that would be reasonably related to a waiver initiative tied back to the three-part aim, and you would then be in that safe zone, as we call it. So what the CMS MSSP and its extension of those waivers allow for is it's really a more favorable legal environment. So it starts to help you reduce those restrictions that we have dealt with for so long in our industry and really help us move forward when we're looking at, I've got a network of physicians, I've got our hospitals, our skilled nursing facility, all of those components of the care continuum, and now we can work together to control cost, design redesigned care processes, implement across the system efficiency. So, looking from, inpatient care, post-acute care, and how do we as a network drive that cost down and legally incentivize the right behaviors to get us to that point. And really throughout it all, promoting accountability for the quality cost and the overall care for our population of patients. So when we look at using the MSSP waiver, it's really important, and I tell our clients and anyone who's going down this road of the MSSP, make sure that as you're looking at that safe harbor, as you're moving into that roadway, always be mindful that these are the items that will keep you in the safe harbor zone. You don't want to fall out and potentially end up in non-safe harbor zone. So the ACO has a participation agreement with CMS, and it's in good standing. It meets regulatory requirements, meaning governance, leadership, and management. And I'm going to just talk a little bit about this here. There are specific requirements that CMS puts forward in its Medicare Shared Savings Program. And so we really focus in on this, that you've got to comport with their governance and leadership and management requirements to stay within the safe harbor. So if you do have a CMS MSSP, I encourage you all to just go back and make sure that you do have these in place and that they do align with the program requirements. That the governing body is made and authorized to bona fide determination that the arrangement reasonably relates to MSSP purposes. So what this means is that we're going to present the best way to do this is have your attorney craft what we call a white paper, present that to your board, and make sure that it ties back to the three-part aim, whatever that initiative might be. And I'll give you an example. It could be a cardiovascular service line initiative where you're looking at, your supply cost in your EP lab, for example. And you really want to take out that variation and move your electrophysiologist down one roadway, if you will. And we know how oftentimes that can be so challenging to do. But when we start looking at, we're going to be able to provide higher quality of care, reduce the cost of care, and improve outcomes, any one of those three aims would reasonably relate to MSSP purposes. We would articulate that in a white paper, present it to our board, have that approved, and then we would be meeting all of these other requirements within that safe harbor. I will also tell you that with these waivers, it does not apply only to your Medicare fee-for-service population, but cuts across to all of your patients, meaning you're not just focusing in on service line improvements or population health initiatives for Medicare fee-for-service beneficiaries, but your entire patient population.
So Deanna, hey, just real quickly, if I could just jump in real quick. Sorry to interrupt you, because you made a really, really important point for our audience there. A couple of them actually on this particular slide that are critical to all of this. So one is that the notion of using these waivers can allow you to do things, create proper incentives for your physicians to I'll say benefit from performing activities that serve the three-part aim. And up until this waiver notion, it's been very, very problematic for hospital organizations and other organizations, frankly, to incentivize their physician partners to do some of these things. What the waiver is allowing folks to do is to explore unique ways to do those things. And I know, Deanna, you're going to get into some specifics here in a little bit, but I just wanted to point that out to everybody, that what we're talking about is using these anti-kickback statute waivers and other waivers to provide a little more flexibility in what you're doing with your physician partners. And it's really, really critical, and this is a part that we wanted to make sure that didn't, that we didn't blow through too quickly. And then the other piece of this on the documentation side is you've got to properly paper them. So you can access the waivers, you can use them for good business, for improving the outcomes and quality of healthcare, but you've got to have your ducks in a row in a very, very disciplined fashion. So here's another area where we would strongly emphasize making sure you're talking to the right attorneys who know how to navigate this stuff, because it's a very, very powerful tool from a strategic standpoint, but you have to be very, very disciplined about it. Thanks, Deanna. Sorry for interrupting.
Yeah, no, I think that's right. And, I can't quite talk about that enough, that this really does give you that protection for true integration. And I think about it as now we can break down those barriers. We can truly collaborate with our physicians, our vendors, our hospitals, bring those partners together, those that, provide, receive, and pay for healthcare, collaborate, innovate, and transform our delivery system. And that really is what the MSSP helps us to do. So it moves way beyond just gain sharing with CMS, because I think that most who have already started down this road have quickly realized there are so many more benefits, up to and including single signature contracting. So it's just very, very powerful. Make sure that with the waiver that you are providing public disclosure on your required CMS ACO website, the arrangement, the description. You don't have to include the financial or the economic terms of the arrangement. So now we're going to get into some specific examples of the initiatives. We have helped groups put together what's called a physician reward and recognition program. And this, if you think about if you are employing physicians as a hospital, you bump into those fair market value guidelines, which we know we have to have, and we've got to be mindful of that. But what this allows us to do is take, for example, physician dashboards, and we're measuring, quality, good governance, efficiencies, those types of things. And we're looking at how do we then start instilling the right behaviors in our provider network to really drive quality, reduce cost, help us with our initiatives that as a network we need to reach. So with this physician reward and recognition program, it cut across all the physicians in the network and really started recognizing by specialty those high performers. And what this allowed for was that safe protection of an additional legal incentive that recognized the physician. The client had called it sort of a work-life balance reward, that they could go out and choose the sort of whether it was a mini vacation or go to a spa, get their car detailed, whatever that was, and the client would then reimburse them up to $500. Didn't just give them a check, because I think we all know that that would just go into a savings account. We wouldn't reach that work-life balance and keep driving that high quality, low cost. We also had looked at, with one of our clients, there was a vendor that came to the table, and this was for remote monitoring, so in the cardiology space. And they really wanted to help support cardiology clinics in the cost that, they felt the cardiologist on the professional fee side, they don't have enough in that to underwrite the cost to put forward this evidence-based care pathway using this remote monitoring solution. So what we were able to do is, with the MSSP waiver and being able to reasonably relate that program back to the triple aim, be able to prove that there were higher quality outcomes with this remote monitoring service than the cohort that didn't have remote monitoring service, that it was a cost reduction in that longitudinal space, that we then brought that monitoring solution into the MSSP by way of, if a cardiologist were to trigger the use of this vendor solution in that evidence-based cardiology care pathway, we were able to then pass off some earnings from this vendor through to the cardiology group to help them underwrite the cost of that solution. So this is just one example of some of the work that can be done using the waiver. The next one that I think is really exciting when we're talking about expanding our networks, that true integration, is creating specialty high-value networks. So if we think about, I'll use orthopedics as an example here. We've got a really high-performing orthopedic group in our network. Great quality, appropriate cost. They've got really great outcomes, good access. And we want to make sure that when we've got patients that need orthopedic care, they're going to be coming to the center of excellence, if you will. So it's not that we're mandating the referral into the center of excellence, but we're helping to drive that by using really good evidence-based care pathways. And what the CMS waiver was able to allow the client to do was to put the pathway together between primary care physician clinics and the center of excellence, such that every time that pathway was triggered, the ACO could help underwrite the cost of that and help support the primary care physician in making sure that they use that evidence-based care pathway, they got the patient to the highest quality center of excellence orthopedic care, and then there was good continuum of care work within that pathway. So you can hear how we're able to legally incentivize the right behaviors to drive the triple aim. Just some general examples of waiver initiatives to help you think about, what are some of the things that, as whether I'm in a physician group, I'm in, an independent hospital system, I'm integrated, whatever that looks like, what are some of the things that I can be working on? And if you look through these sort of stair-stepped arrangements, we can start legally incentivizing doctors for really good evidence-based management of patients, on the inpatient side. So if we're putting forward in our clinical quality teams, some different care pathways that we would like for our physicians to use, and I'll go back to cardiology. So maybe it's, a post-CABG patient, and we need certain protocols to be followed, and it's good medicine. We might have a few CT surgeons that they've always done it this certain way, and it's really hard to change that behavior. Well, we can start legally incentivizing to get that behavior changed to make sure that they're falling into the three-part aim and helping us to move forward with better quality of care and outcomes for our patient. And then doctors being legally paid performance-based incentive payments. So this can be part of the MSSP. So as you're getting those gain sharing dollars back, you've got specific formulas for reimbursing or remunerating the physicians in your network. But this also goes toward if you've got service line improvements that you're looking to make, and as you're pulling down that cost and you're improving quality, you can now move beyond those traditional co-management arrangements, which have been really great for so many systems, but this is sort of taking it that step further to now we can actually gain share with our physicians as they're helping us to make those improvements in our service lines. And then doctors being paid a portion of savings for decreasing hospital cost or increasing hospital efficiencies. And there are so many examples of this. I tell clients all the time, just think through some of those, thorny, quality issues that you've been struggling with, or, cost. All of those things that we have been working with our physicians on to move the dial and start mapping out, how does the three-part aim inform this, and how can we move forward in that clinically integrated space to make that change? And Emily, we have a polling question.
All right, our next polling question. I understand strategy of a CMS MSSP as a vehicle for integration and a strong tool for the journey to value. And your options are yes, no, I'm starting to, but I need more information. And for those of you that would like a copy of today's slide deck, you can download them from the folder that says Slide Deck and Handouts to the right of the slide view. We will also be sending the slides via email after the webcast. I'll give everybody a few more seconds here. And let's go ahead and take a look at the results. So 47% say yes, 8% say no, and 44% are I'm starting to, but I need more information. Deanna, back to you.
Terrific, thank you. So the benefits continue. So as we are participants in a CMS MSSP, I think one of the greatest things, if we haven't, as an industry or as a healthcare system, participate in a lot of managed care, this allows us to start getting claims data so we can start looking at what is that sort of movement of my population. Now I'm able to actually see if I've got out migration and, where is that headed to and how can I start controlling that, because now I need to be responsible for that, total cost of care, the quality, access, all of those great things that we look to do when we move further and further into value. And so with the claims data that's coming in, there's also that need to make sure that you've got a really good data analytics partner to take that information, consume it, and then be able to transfer it so that it's actionable, and you're also giving direct insight and feedback to your physician network so that you can work together to start, reducing that cost within the network and moving forward with some of those quality initiatives. Macro reporting, we're going to just talk a little bit about this because one of the benefits that we have seen, and the physician organizations are really, really quite excited about this, it helps to ease the burden of that quality reporting. I don't want to say, I'll say burden again, because I think everyone has said this is such a hassle. We know why we have to do it, but it has really caused, extra cost in our physician groups and administrators trying to figure out how to submit the data. Different specialties have different data points that they need to submit. So when the physicians become part of the CMS MSSP, you're submitting one data set across the network. The other real benefit of this is that the MSSP is submitting on behalf of its physicians. So that has really been, just a wonderful advantage or benefit to our physician groups, that, there's already so much that they're working on and so many, I'll say hassles with the day-to-day operations, and you just really being pulled in a million different directions, and now trying to figure out, especially if they're multi-specialty group, all of the different data set requirements. So being part of an MSSP has a tremendous advantage in, removing that hassle from our physician groups and being able to submit the one data set.
Deanna, can you just quickly, sorry to interrupt you again, on that. So are you saying that the ACO reporting requirements cover the macro reporting requirements completely? Are there areas that fall outside of it? And if so, are you suggesting that the ACO develop reporting to fully cover the macro reporting requirements, or maybe a little bit more detail on how that works?
So for the quality reporting, CMS requires that the MSSP submit on behalf of the participant. So the physician groups, any physician that's part of the MSSP, you're having the data submitted on behalf, for you through the CMS MSSP. So now you don't have to worry about making that submission. And there are a few other components to MACRA, but we can certainly, get through that perhaps on another webinar, or if anyone has any specific macro questions, please shoot them our way and we will make sure to address those. So when we look at physician integration, we know that this has been something in our industry that, for hospital systems, for physician groups, we've been looking at how do we start to, aggregate our networks and really broaden and deepen our physician alignment. And we now have options. So you can still move forward with full employment, but if you're in that state with corporate practice of medicine, we know how that works. So you can also move forward as an MSSP participant. So this pulls your physicians into your network without having to have that full employment model. Also, we hear a lot of, our primary care physicians, which this is another area. Primary care physicians can participate in one CMS MSSP for the purposes of gain sharing. What we often run into when we're building out these broad and deep provider networks, that many of the PCPs are already participating in a CMS Medicare Shared Savings Program. And so they'll come back and say, no, I can't sign into yours because I'm already participating. Well, the good news is we can sign them in as an other entity, or what I had just call an affiliate. So they can't qualify for the gain sharing dollars when they're already participating in another MSSP. But this does pull them in as part of our clinically integrated network, so that way we are continuing to build that very broad, deep physician network and being able to use that ACO waiver to start legally, incentivizing and shifting those behaviors for quality and cost. Now I'm just going to talk a little bit about the MSSP application timelines. I've given you what we have just gone through, which was the July 1st start date, so you can see that there in this slide itself. But what we're looking at right now is if you want to apply to get started for January 1st, 2020, you need to get your notice of intent to apply in between June 11th and June 28th. Step 2 would be submitting the application between July 1st and July 29th. And I will just sort of say that with submitting the application, I would encourage all of you to go online if you're thinking about starting an MSSP and look through those application requirements, because you do need to start preparing that groundwork and getting documents ready, so that way when the filing time comes up, you're ready to go. You will have to respond to requests for information throughout the summer and fall of this year, and that's really where CMS is looking at what you've submitted. Do they have questions? Do they need you to make amendments or addendums to your participation agreement? Many different things that fall into that request for information. During this time period, they will also let you know the approximate numbers of attributed beneficiaries, which, going back to Karl's slide, you must have a minimum of 5,000 to even qualify to be considered for the CMS MSSP. And in December, you'll be, if you qualify, sent your agreement to sign and off and running in January. And so I like to just really sort of bring it all together with this ACO Continuum. And if you look on the outer ring, we can see that, there's direct to employer, payer contracting, hospital partnerships, physician integration, market expansion, quality improvements, cost reduction. I think that most of us on the phone today will look and say, gosh, I'm dealing with probably 75% of these areas. And then if we go into that inner ring, we can see where the CMS MSSP helps us to really move forward with that clinical integration strategy. And then that outer ring, we start really just, it becomes easier and easier to where it's, I think you will all understand when I say it's your flywheel. And now you're able to start generating those direct-to-employer contracts because you've built out your very broad and deep clinically integrated network. You've worked on your costs so that you've been able to pull your costs down while improving quality. Perhaps you're in a market where you would like to affiliate with a hospital, but not in that full M&A way. You really are just looking at how do we partner and bring our networks together to start working on some bigger endeavors around quality and cost. And the CMS MSSP will allow you to do that without that full merger or acquisition. And then we've talked about the beauty with physician integration and having options now where if you don't want to fully employ or run through a medical foundation, we can still build a really great network through this MSSP. And so we think about moving beyond CMS MSSP as that just sort of basic, we're moving forward with Medicare gain sharing, but really evolving it to where it becomes part of your strategy and allows you to execute with excellence. So looking at the imperatives in your market or your region and thinking about, do I have areas where I would like to drive change, engage our physicians, things that I think about that truly relate back to the purposes of the Medicare Shared Savings Program, and how can I use the MSSP waiver to help get us through some of the really challenging times and into our more strategic imperatives. Oh, we have another polling question.
All right, on to our final polling question. I understand the benefits of the CMS MSSP waiver in collaborating, integrating, and transforming my physician network and delivery system. And your options are yes, no, or I am somewhere in between. And once you have completed all CPE requirements today, you will be able to download a PDF of your CPE certificate from the certification widget to the right of the slide view. I'll give everybody a few more moments to make a selection. And let's go ahead and take a look at the results. We have 49% say yes, 3% say no, and 47% are somewhere in between. Back to you.
Great. Thanks, Emily. So just a couple of things before we go through the last couple of slides here. The couple of the polls indicated or asked about sort of the audience's comfort level with a couple of notions. One is how ACOs may or may not be a vehicle to getting into the value-based world in a successful way. I'm paraphrasing or rephrasing, however you want to characterize that. And then this last one, which is how to use the ACO as a strategic tool. So on the first one, the way that CMS has set these up is, and we didn't go into these details, but because this webinar was really set up to talk more about the strategy piece of it. But the way you can ease into these things by virtue of the way the model actually works with sort of early on being just about upside, allowing you to get your arms around how to analyze the performance data, understand the attribution model, which is how patients are, or how Medicare beneficiaries are assigned to your ACO, and get your ducks in a row in terms of the network depth that I mentioned early on. So which physicians you're contracted with, which physicians are part of your ACO, part of your network. There's a lot of work that has to go into that. The way so you're able to actually, I don't want to say tiptoe because that's not a fair representation, but it does allow you to sort of migrate over time, getting into the downside risk models with a little bit of practice before you jump in all the way on that front. And we can talk more about that later. If you have any questions about that, as Deanna mentioned earlier on, reach out to us and we can talk with you guys more about that if that's something of interest. But at the end of the day, you're absolutely able to migrate through the various stages of an ACO before you have to start taking downside risks. So that's number one. So this is the design, is to allow organizations to learn and ease into it a little bit. The second notion on the strategy side, what Deanna was talking about in terms of using these waivers, the ability to do things and partner with your physicians in ways that can give you the opportunity to incentivize them to perform those activities that would drive coordination is something that organizations have been struggling with for a long time. And so if you set up your ACO properly and you utilize the waiver mechanism, you can do things like pay your physicians, I don't want to say stipends, but amounts for performing certain activities. And an easy one to wrap my head around, at least, is, say you want to pay your physician an extra $50 or something along those lines. Please don't use that number specifically. But some amount of money to make sure that they get for every senior that's in the ACO, get them in for an annual well visit to make sure that you're keeping on top of their health, making sure that they are getting their meds, taking their meds, all these different things that they have to do to maximize the quality of their life and their health opportunity. Those things are allowed those types of things are allowed under these waivers. What it does inherently is it's going to provide a stickiness to your physician, the physicians in your marketplace, because what you're doing effectively is you're looping them in to this process and giving them better tools, more opportunity to take care of their patients. So from a strategic standpoint, what we're saying here is that you can use this model to create a tighter physician network relationship. So those are the 2 points I wanted to jump in and add to this before we closed out here.
Yeah, and I think the best way, when I look at this, if I think about this as I am deemed clinically integrated, I've got, and I'll put quotes around it, a CIN. That helps us to really hone in on the work we can do to drive the physician engagement and grow that alignment in that network. So I think that's, very well stated, Karl. Thank you so much. We do have support for success, as we like to call it. So, absolutely reach out to us. We've put together a really great toolkit that helps you identify, am I ready to jump into a CMS, MSSP, looking at the different departments and what do I need to get this going, and then help you to score, here's some areas of priority that I need to start looking at to get ready. And then comprehensive planning template with success stratification, being able to map out short to long-term objectives that will help underpin those really big strategic imperatives that you're looking at for your physician or integrated network. And I think we're going to open up for questions now, Emily.
Great, sounds good. If you have a question for today's presenters, we do have some time to answer your questions. You can submit those in the Q&A window right beneath the slides. Now let's see here. How can FQHCs participate in MSSP?
So FQHCs are terrific to participate in CMS MSSPs. We've seen that sort of as an early trend across the country and a lot in the Pacific Northwest into the West Coast. So absolutely, it can be done. It's great, and happy to share more.
Thank you. Our next question, can I wait and apply next year?
You can wait and apply next year. I think Karl's probably going to jump in on this, but if we're not moving forward with building out our networks and that clinical integration, looking at that broad and deep physician network and engagement, rest assured that someone else in your market is, and you think about it as networks narrowing further and further, and the longer I wait, am I going to still be as viable as I once was?
Yeah, and I definitely would concur with Deanna's comment there, or her response. There's, because of the steam that we're seeing behind this strategy, the trends that we showed you a little bit earlier in terms of the number of organizations getting into this model, of course you want to be thoughtful and you want to be disciplined and have a plan, but the sooner the better, because folks around you are going to be doing these things. The growth we're seeing in this space, really what we're seeing on the management services organization space to support these entities is really pretty dramatic. And so I would just add that yeah, you want to be thinking about this. If this is something that's at all a remote possibility for your organization, you probably want to get serious about vetting the opportunity and making sure that you're thinking about what's happening around you as well as within your organization.
Right.
All right. We have a couple more here. Are there really waivers from fraud and abuse?
Absolutely. That was part of the design when CMS, out of the Affordable Care Act, when they were contemplating, how do we get the industry to really start transforming and moving that cost dial down while pushing up quality. So absolutely the CMS waivers exist, and they are designed to relate back to that three-part aim and do exactly what I've said: pull down cost, improve quality, and provide better outcomes for our population. And I think if we just look at it, it's doing the right thing for our patients and our population, and I think that's what's so brilliant about it.
Yeah, and I would also add that so we're not saying that we're definitely not saying that you're protected from fraud and abuse directly. You again check with your attorney on that, but I'm pretty sure that that's not the plan here. What we are saying though is that some of the activities that have kind of been considered borderline and a little scary for organizations, even though we know they're logical, good business and they're good for our constituents, our patients, our health plan members, have been frowned upon and been considered taboo at the least. So what you want to do is you want to make sure that what you are doing meets the triple aim, meets the three-part aim requirements, and actually does some good in terms of coordination, quality of care, and efficiencies. But yeah, no, I just wanted to make sure that we very clearly are saying no, it doesn't protect you if you commit fraud and abuse, but what it does is it allows you to do good things that have historically been a little bit gray because of the specific requirements around hospital and physician relationships.
All right, time for a couple more. Can I use the MSSP to drive a Medicaid strategy?
Yeah, Medicaid has started some ACO pilots state by state, but what I would say about using the CMS MSSP, if you have a large enough population in your Medicaid, like I'll go down managed Medicaid population, then yes, you could absolutely sort of tie these together. But I think just taking it and looking at, if I've got a managed Medicaid population that I'm working with, does the CMS MSSP provide benefit to it? And we always look at, that value-based roadway that we're building, and how can that translate into whatever type of network I'm working with, whether it's direct to employer, it's a Medicaid strategy, it's a commercial ACO, all of those different networks that we're working on. This is a really strong foundational element, but I would encourage you to look at the states that do have Medicaid ACO pilots and check into those. There's some really great work going on.
All right, I think we have time for one more. How do I know which model is best for our hospital system?
Gosh, Karl will jump in on this too, but I think it's, looking at how comfortable are you in that risk corridor, and how well do you know your population, if you will. Do you have great population health analytics already? You've got a good handle on, that value-based shift, if you will. But you've got to be mindful that if you don't do well in the risk corridor, you do have some financial burden on you. There is payback to consider. So, we always encourage, if you're not real comfortable yet, just start with upside only and get comfortable, know your population, get your tools in place and your strategy as you shift more and more down that risk-based corridor.
Yeah, I would just agree with all of that. I would add that specifics around what you know about your the Medicare population around your facility. I mean, you know, from a hospital perspective, you're talking about a geographic location for the most part. So how, you know, tight are you with your core physician specialties that provide services for seniors? How good are your relationships with primary care in your marketplace? Because ultimately that's where the attribution gets assigned to. So there are a lot of really important considerations. It's a really great question. There are, as Deanna said, the models that allow you to go upside only, but this really becomes, it's the same questions that you should be asking yourselves about getting into any risk contracts, even if it's some sort of subcapitation with a health plan. It's how well do you know the market that you're in, and how good are your partners? How good are those partnerships, I should say.
All right.
Thank you. Okay, that is about all we have time for, as we are at the top of the hour. If you have any other questions for Deanna or Karl, you may reach out to them directly. We did have some questions that we didn't have time to answer, and we'll be happy to follow up with you after the webcast. And I did want to direct everyone's attention to the slide deck and handouts widget, where there is a link to our 2019 Healthcare Conference. That is our annual conference, and you can learn more about that within the link. Thank you so much, Karl and Deanna, for a great presentation today. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts icon to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy will be emailed within 2 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.